Hi, Brian Kaufman, a retired family doctor and a CLL patient myself, Chief Medical Officer at the CLL Society here at ASH 2019.
Neil Kay. I work at Mayo Clinic in Rochester, and mostly I work on CLL.
Dr. Kay, you've done some groundbreaking research on understanding how the microenvironment supports the cancer cell. It's like seed and soil. I mean, the cancer, what happens to the cell is important, but it needs growth factors to help it live. Can you explain that to patients? And there's one called tumor necrosis factor, or TNF, that you've particularly zoomed in on. Can you explain that so patients can understand why that's important?
Absolutely, and thank you for that question. So we have been very interested in looking at hematopoiesis. That is not...
So hematopoiesis, explain what that is.
Hematopoiesis is the growth and generation of all the cells we need to live and to be healthy, like red cells, like platelets, like immune cells that we need to be to avoid infections and even other cancers.
And that's happening in the bone marrow.
Happening in the bone marrow primarily, and it needs to be able to function properly in a continuous fashion. Otherwise, we would be deficit immediately, because most of those cells are turned over, a lot of those cells are turned over quite quickly.
Like our red blood cells live about 100 days,
right,
roughly.
Right, but some of the other cells that we call innate, that is, they're responsible for first-line defense, like neutrophils, and some of the monocytes, these cells have much more rapid turnover, and it can be measured in maybe a few hours to a few days. So these need to be replenished continuously. And so we have been very interested in trying to ask for untreated CLL patients, is hematopoiesis working properly? And what we have found, and we've actually had one paper published in leukemia, but also have an abstract today, here today at a poster session, where we document disordered hematopoiesis. So that means that the bone marrow is not functioning normally. And what's interesting to us is it does not appear to be related just to CLL tumor burden. There can even be minimal tumor burden in the marrow, but it's not just simple replacement.
So let me ask you about that, because that's what we always talk about. There's just not room on the factory floor.
Right.
And when we get back our biopsy report as a patient, you say 70% involved, 90%. So if it's 90% involved, only 10% is not enough room to grow all the red blood cells. But you're saying it's more than that.
It is more than that. When we account for the tumor involvement, just take that away, and there are ways to do this. It's still clear that there is obvious dysfunctional hematopoiesis, and that does at least impact on the ability of the innate cells, the neutrophils, the monocytes. There are other cells, dendritic cells, that we need to be healthy.
And to fight infections, and to monitor for cancer, and
Absolutely.
all kinds of stuff.
Yes.
Yeah.
So what we have been, since we observed that, this poster today, and what we're presenting at ASH this year, is some mechanisms that explain that. One of the interesting observations that we found is that the transcription factors, which are responsible for normal hematopoietic cell function, appear to be aberrant, very aberrant. And there's at least 3 of them. I don't know if you want me to list them. I could mention
Sure,
them
please.
quickly. There's GATA1 and GATA2 and a PU1.
Okay.
And forgive the jargon, but those 3 transcription factors need to be in the right balance in order for the hematopoietic cell, the progenitor cell, to make the right progeny, to make these innate cells.
For the mother cell, sort of this more stem-like cell, to know how to give birth and what's needed.
Exactly. And so, observing that, we also knew that tumor necrosis factor, or TNF, is able to recapitulate those abnormalities almost exactly when we culture TNF with normal human hematopoietic mother cells, progenitor cells. And when we add a TNF blockade, using, for example, a monoclonal antibody that will block TNF, we reverse it. And it turns out that TNF is produced by CLL B cells in a very consistent and almost automatic way. So we believe one of the implications of this is that even in early stage, even in untreated CLL, that there is not the capacity of the bone marrow to function and to replicate the innate immune cell subsets that we need to be healthy. And that's the essence of our current work.
So One other area of hematology is this anemia of chronic inflammation. And is that the tumor necrosis factor mitigating? So people with rheumatoid arthritis that isn't treated, people with inflammatory bowel disease, things like that, are often anemic. And it's not from blood loss or low iron, it's because the inflammation in their body turns off the bone marrow. Is that the same thing?
It's like that. The subtle issue here, or not so subtle, is that we do believe there's a profound problem for production of these immune cells that we need to be first-line defense mechanisms. Whether or not this relates to dysfunctional red cell production, erythropoiesis, we're suspicious that it does, but we don't necessarily see a strict correlation between red cell production and what we're observing.
Okay.
So there's a little bit of a difference there.
And are there therapeutic implications for this? Because we have drugs that affect tumor necrosis that our rheumatology colleagues use all the time.
Exactly. We're very, very interested in drugs that will block TNF, and that could potentially help to reconstitute normal hematopoiesis, normal bone marrow function. There are subsets of individuals who have, like you said, inflammatory arthritis, where they're on these blockades, TNF blockades, for years. And we think there may be some interesting therapeutic or investigative aspects that need to be done. Are we helping them with their bone marrow function early on? That's one hypothesis I would make, but perhaps in the long term, shutting it off completely may not be such a good idea. So there's still a lot to learn in that way.
Exciting research, a little complicated for patients, but still important to understand what's going on in the bone marrow. Any final thoughts or anything you think patients should take away from this?
Well, one thing they could take away from this is that the ability to explain infections, the ability to explain perhaps a lesser response to vaccinations, may in fact to some extent be related to this disordered hematopoiesis. And short of actually being treated for progressive CLL, as we continue to work on this, there may be consideration of maneuvers that would reverse the disordered hematopoiesis perhaps even earlier, and this might even be before requiring traditional therapy for obvious progressive CLL.
And that's one of the things we talk about with patients, is that even when you're first diagnosed, even before you have your first treatment, you are immune compromised even at that point.
Exactly.
And if you're behind in vaccines, if you need to get them sooner, because you're not going to be in a better immune state 6 months from now.
I would think that's correct.
Yeah.
I mean, I don't want to be too glib about this because every individual has their own clinical course, but I would think that from these studies, we would be concerned that even early on in the disease course, the patients would be at risk, and they probably should consider thorough vaccinations, completing those as soon as feasible.
Dr. K, very exciting research. Thanks so much. Thank you. Thanks.